Broadcast is now starting. All
Hello
attendees are
everybody,
in
welcome
listen-only
to
mode.
the IAPB Africa Focus on Glaucoma webinar. Thank you for joining us today, and thank you to all our speakers for participating in this webinar. Before I hand over to our chair, Fatima Chiari, I just want to talk you all through some housekeeping bits before we start. So just to let you all know that microphones are muted apart from the speakers, and this ensures a better quality webinar. So we aim for the session to be interactive, and attendees will have the chance to ask questions during the question and answer session at the end of the webinar. So if you have any questions for the presenters, please do type them in the chat box. The chat box can be found on the right-hand side panel of your screen. You can post questions either during or after the presentations. If you do have any technical difficulties, for example, with sound, with able to log on, you can send us a message in the chat box. I would also suggest that it's a good idea to close down all of the web applications, for example, Google, Outlook, Skype, anything at all that you've got open, as this will ensure a better quality of webinar for you. And if you do have headphones, please do use these. We aim for the recording to last around an hour. Apologies that we have gone slightly over, so it will be just after 3 o'clock that we do finish. We are recording the webinar as well, and it will be uploaded onto the IAPB website afterwards, and we will send the link round in a few days. And finally, before I hand over to Fatima, just to let you know that we will be sending you a survey for feedback at the end of the webinar. So please do provide us with any feedback or comments that you may have. I hope you enjoy the webinar, and I'm now going to hand you over to Fatima. Thank you, Fatima.
Hello, everyone. Thank you, IAPB, for this Focus on Glaucoma webinar. Much appreciation to Simon Day for putting all the speakers together. He's the Regional Program Coordinator for Africa Region. And thank you to Rachel Book. She's Membership Services Manager for IAPB. I am Fatima Chiari, consultant ophthalmologist and chair for IAPB West Africa. It is my honor and privilege to be chairing this webinar on Focus on Glaucoma, especially for this year, which is year 2020. So we speak on the subject of glaucoma broadly, but specifically we are so excited that we have come together as glaucoma specialists and eye doctors to develop a toolkit for glaucoma management in Africa. The aspects of the toolkit will be discussed today. Please, you're welcome to make your comments or ask questions, which will be answered at the end of the webinar. Please welcome our speakers today. But before I go on, permit me to just give a few highlights on glaucoma. We know that glaucoma is a group of diseases that have a common endpoint with an optic neuropathy associated with characteristic structural damage to the optic nerve and associated with visual function. So two important things, structural damage and visual function. Glaucoma. Well, we know that glaucoma is the most common cause of irreversible total blindness, and it accounts for 16% of blindness, which is avoidable in Africa. And up to 85% is open angle glaucoma. About 5% of those with glaucoma are aware that they have the disease. There are more men, and Africans have an undue higher risk of getting the disease. It is actually a disease that affects everyone all over the world, but it is higher in Africa, as you can see from the graph that I'm showing you. 4% of those aged 40 years and above are mostly affected in Africa. So how do we see glaucoma at presentation in the hospital? Well, as you can see, because only 5% really know that they have the disease. Most come blind, and mostly at a stage where focus of treatment is to prevent further vision loss, and one eye is already blind. So our aim here today is to shift paradigm to recognize that glaucoma blindness is avoidable, and we are all working together to strengthen clinical services, to ensure or find strategies for earlier detection of glaucoma, and then strengthen health systems for governance. So I'd like to talk a little bit about the toolkit. We have a glaucoma management toolkit, which is being developed and piloted. So we're fortunate to have two main programs going on in Africa. One is the Silent Thief of Sight program, which is a project for Light for the World in Burkina Faso, Ethiopia, and Mozambique. And we have Keep Sight project, which is by Sight Savers collaboration with Allergan, and phase 1 is in Nigeria. Kola will be telling us a lot more about that. So it's a wide range of services, and one of the things we want to do is to ensure that we have a practical guideline that we can apply. So the toolkit has 3 parts. The first part is a clinical tool, which contains a checklist, a stage and risk calculator, and then algorithms for dealing with specific situations. And then it also tells us how to manage certain conditions, and there's a bit on current opinion. The second part is about service provision, because we know that glaucoma, we cannot contain it only in the hospitals. It has to be a community-based program. So we are trying to decide levels of glaucoma care, models of service delivery, and financing. And then we have an equipment list that we can handle, and then advocacy to ensure that these things are brought into use and awareness of people. Then there's a third part, which is mostly about information. So today on Focus on Glaucoma, we're talking about these things. And I'd like to introduce to you Nkiru, who will discuss implementing the clinical aspect of the glaucoma management toolkit and guidelines. Nkiru is a consultant ophthalmologist practicing in Nigeria. She's the current governor for Africa for World Glaucoma Association. Rachel?
Hello. Hello. Good afternoon. It gives me great pleasure to be presenting the implementation of the clinical guidelines of the toolkit for glaucoma management in sub-Saharan Africa. I want to thank the working and writing group that puts this toolkit together, and also wish to thank the IAPB for putting this webinar together, which focuses on glaucoma in Africa to mark the World Glaucoma Week. As Fatima had mentioned, I'll be discussing the implementation of the clinical guidelines. I'll talk a lot about the clinical guidelines itself. Coincidentally, I was not part of the working or writing group of this glaucoma toolkit, but which gives me a newcomer's view of the document. I've gone through it, and I think it's a great document that will both standardize and enhance good clinical care for our glaucoma patients in sub-Saharan African setting, a type of preferred practice guideline pattern. Now, the clinical the clinical guidelines has 5 different parts. The first one is a checklist that deals with can be used in the clinic to facilitate good clinical diagnosis, risk assessment, and management of a glaucoma patient. The second section, I said it has 5, is a guide on staging of the disease and risk assessment of the patient. And this enables the clinician to determine how aggressive the treatment should be. Then the third is a specific decision algorithm for treatment of different types of glaucoma. While the fourth, it's a resource or reference section of how to conduct or carry out different clinical procedures that are mentioned in the checklist. The fifth is a current opinion section for different areas of glaucoma care, which may be in use in other parts of the world, but we don't have enough evidence yet to include it in the algorithm for the Sub-Saharan African setting. Now, so we come to the first one section, which is the checklist. So it's just a general overview of the clinical guidelines. The first section is a checklist, and it has actually 3 parts: the new patient's glaucoma evaluation form, the return or the follow-up patient evaluation form, and the eye department's local information form. The new patient's glaucoma evaluation form actually deals with the demographics, basic medical information, and relevant clinical examinations, procedures, and investigations, that are necessary to make a diagnosis. So ranging from visual acuity to pupil exam, gonioscopy, CCT, CVF, OCT. Now, some of them are laid out in a graded form that can just be ticked out. This information, they are presented in a user-friendly color-coded format. And it also has tick boxes, which makes it quite easy to use. In fact, with the tick boxes, the information required can be easily completed, either whether one is using print or one is doing electronic formats, as many of us are transiting to the electronic medical records. The return patient form is basically same as the new patient form, except that it has targets IOP included and changes when it has to do with progression regards visual field and OCT. Then the third form, part of the checklist form, is that of the eye department local information. This is a very interesting one for me because it's actually requesting information regarding the local area regards glaucoma, like the estimated number of persons with glaucoma, and then the clinician and also sees imputes the number of patients that they have in their clinic, and which gives him an idea of the undiagnosed patients in the community, local community, and that hopefully would drive the clinician to see what impact they are making and hopefully take the service from clinic to the community. Section 2 has to do with staging and risk assessment, and this section discusses the different criteria for staging glaucoma at presentation, and which could be either early, moderate, or advanced glaucoma. It also has a risk calculator scoring system that predicts the patient's risk of sight loss in their lifetime and categorizes the patient into low risk, medium risk, or high risk. And then there's a combination platform for both the staging and the risk calculator. So on that platform, you can be able to now say, okay, this patient has early stage glaucoma and low risk, and it enables the clinician to determine what the urgency of treatment and the referral that the patient might need, or at what level of care the patient is most appropriately seen after that initial diagnosis. So these are some tools regarding the staging of the severity of the disease, the DDLS, and then the scoring and the staging of the disease. The risk assessment has so many varied risk factors that are put into cognizance, including access to health and socioeconomic status. All these have numbers given to them, and they are scored, and that enables one to see the score, whether the patient is high risk or low risk. For instance, if a patient is early stage and low risk, the patient can do well in under primary care. The third is the pathway specific decision algorithm that enables one to simplify. The section actually simplifies the pathway to a clinical decision, and both regarding diagnosis and how best to treat that patient. It's presented in form of flowcharts, which can be pinned in the clinics for ease of reference. And this generally makes everyone's life better, both the consultants and the residents. It covers all the different types of glaucoma, ranging from ocular hypertension through pediatric to secondary glaucomas, and even glaucoma coexisting with cataract, what best to do. And so that's example of that for normal tension, glaucoma, and cataract. And then the fourth section has to do with the resource and reference section, which is a section that deals with how to do it. So it's like a signpost for useful resource that has been chosen from a myriad of resources from the internet, and the layout is easy to follow, to read, and also it's not long. So one can easily check on the resource of interest and easily click on it and gets links to the internet on that particular subject immediately. It's time saving and really will be really helpful to those who are rendering care. It covers areas that has to do with examination and diagnostic procedures, laser procedures, and surgery. And then the final section, which is section 5, that's on the current opinion. We know that in resource-limited settings, such as most sub-Saharan African countries are, all the technological advances in diagnosis and treatment for glaucoma are not readily accessible or affordable. So priorities have to be determined based on consensus and current opinion. So this section discusses the current opinion with available evidence on different topics. So we see what's the role of mix in sub-Saharan Africa and combined cataract and glaucoma surgery. So in summary, this clinical guideline toolkit that has 5 sections is user-friendly, is packed with sufficient pointers to assist the clinic to make diagnosis and stage and management of the patient. Hopefully, when it has been piloted and fine-tuned, it would likely harmonize glaucoma care in this part of the world, and the glaucoma patients across sub-Saharan Africa will, as they hope, will likely get standardized care wherever they go. Thank you very much.
Fantastic, Dr. Nkiru Akaraiwe. Thank you so much for this. As you can see, Nkiru was not involved in the write-up. We had a workshop where glaucoma specialists and eye care doctors were brought together to develop the framework for the glaucoma toolkit, and she was not part of this. So basically what we're having now is a review, a peer review. And You can also have a look, you know, have your say from what she has said. And what particularly struck me was the signpost for useful resources. She said it's very easy to read and follow. It has a good layout and it's time saving. Without saying too much, I'd like to call on Dr. Abiba Georges. She'll give us an insight into integrating glaucoma care within existing healthcare setups. Dr. Abiba is an associate professor of ophthalmology. She's the Glaucoma Fellowship Director. They're just about to start specialist glaucoma specialist training in Addis Ababa University. And I'm also happy to say that Light for the World is also supporting some aspects of that fellowship. Dr. Abiba?
Yes. Okay. I'm Dr. Ababa from Addis Ababa University, Ethiopia. First, I would like to thank IAPB and the organizer of this webinar for giving me this opportunity just to discuss on this important topic. And my area of discussion is integrating glaucoma care within existing healthcare setups. The points that I'm going to discuss are the global attention of integrated eye care, briefly in glaucoma in sub-Saharan Africa, also it's mentioned by Dr. Fatima, and the potential existing healthcare programs for glaucoma integration and the minimum requirements for glaucoma case detection. The recent World Report on Vision by WHO has reported that the presence of 2.2 billion people with blindness or visual impairment, and of this 1 billion people are visually impaired because of lack of care they need. And in sub-Saharan Africa, the rate of blindness is 8 times higher comparing to people of the high-income countries. And in this report, glaucoma is mentioned as one of the causes of blindness and vision impairment. And it's also stated that the presence of limited access to eye care is considered as one of the main reasons for the rising people living with blindness and vision impairment. In this report, the main cause of vision impairment and blindness that require national prevention and other eye care strategies are cataract, trachoma, and refractive error. And due to a weak or poorly integrated eye care services, many people lack access to routine checks and are being detected late. And the key proposal of the report is for all countries to provide integrated people-centered eye care services. So coming to sub-Saharan Africa, so it's mentioned by Dr. Fatima, as I said earlier. So the point I would like to mention here is, because of the huge prevalence of glaucoma in this region, glaucoma is a public health problem. And we know that open-angle glaucoma is the commonest form, and pseudoexfoliation is common in Eastern Africa and the commonest in Ethiopia, and the Rwandese are low-tension glaucoma. So coming to glaucoma integration with existing healthcare programs, cataract is top on the list. In this cataract outreach and campaign programs, hundreds, if not thousands of people come for screening. And it's an extensively done program in Africa involving the National Ministry of Health, many NGOs, eye care professionals, and institutions. So glaucoma, can be integrated with such huge services, and the activity of glaucoma that can be integrated are glaucoma health education, glaucoma case detection, and referral. And the second is trachoma elimination program. And as we know, Africa is the worst affected continent, where trachoma safe strategy is being implemented in 29 countries. And the extensive program in the affected countries are huge opportunity to integrate glaucoma. With the safe strategy, health education, mass drug administration, and TT case detections are part of the safe programs. And with this program, glaucoma awareness activity, case detection, and referral can be integrated. So when we look at the 3 common causes of blindness, this could be more efficient, cost and time effective, and accessible if they are integrated and become multi-disease focused programs. And the third potential area for glaucoma integration is primary health care. Primary health care is a core policy of WHO. It's the first level of contact between individual and the health system, the closest to people, and it's accepted as a national strategy and has wide national coverage. Healthcare is provided by suitably trained workforces supported by integrated referral systems. In this primary healthcare, the services that are included are health promotion, illness prevention, care of the sick, advocacy, and community development. With these various activities, community glaucoma awareness, case detection, primary treatment, referral and follow-up can be integrated. And the fourth potential area is the non-communicable diseases. And in this area, the population at risk for both non-communicable disease and glaucoma are similar. And the existing caring units from primary to tertiary hospital make the integration of glaucoma case detection and education feasible with such diseases. And the fifth potential area for integration is the neglected tropical diseases. And this, the underprivileged and living in remote areas are the people affected by the NETDs. And such people are at risk for blinding eye disease, including glaucoma. So integration of eye care within the interventional activities of the NETDs can be essential to prevent blindness. So if we integrate glaucoma with this potential, the huge and potential programs, this increases the presence of option, and this all again increases accessibility and again increases the chance of case detection. And during this week is, we know, this World Glaucoma Week, and the theme of World Glaucoma is green. Go get your eyes tested for glaucoma. And if there are accessible and various options for people to go and check their eyes, the chance of being detected, would be high. And the minimum requirement for glaucoma case detection and management in such integration programs, number one is the instrument required, one is the tonometer, like the eye care tonopen, shots, or others, ophthalmoscope, and if possible, smartphone to take a fundus picture. And we need a trained personnel like optometrists, nurses, community health workers, and the others, depending on the level, and referral system in place. And the most important requirement, I would say, is integration and commitment at global, regional, and country level of eye care programs, supporters, and eye healthcare providers. Cases who can be easily detected by such integrations are those cases with high intraocular pressure, those who have moderate to advanced glaucomatous optic nerve head damage. And those cases who can be missed are those with low tension, low level of IOP, and with early glaucomatous optic nerve head damage. The advantages of integrations, glaucoma integration to the existing health service and eye care programs are: one is it's practical and doable, it's cost effective, and it enables to access the underprivileged communities, and also it enables to pick people before they lose their vision, and it doubles or triple the community service of the programs. And the opportunity, the current opportunity we have is the global interest of provision of integrated people-centered eye care. And it's high time to talk, implement, and practice integrated glaucoma care in order to prevent the huge needless glaucoma blindness in Africa. So I would conclude my discussion by saying the needless glaucoma blindness in the late case presentation can be prevented or minimized by integrating glaucoma education, case detection, early referral, and follow-up system to the existing health and eye care setups, human power, and infrastructures. Thank you.
Thank you very much, Dr. Abiba Georges. This is quite interesting. What struck me here is the people-centered integrated eye care. So if we're going to do this, we might as well start with eye care programs in a multi-disease focus kind of program, which is quite apt. And then we can now, integrate into others because it's people-centered. So it's a whole person approach. The person must be seen as a person, not as a disease. I would like to introduce the next speaker. The next speaker is Svenja Schneider. She is the program coordinator for Light for the World. Light for the World is conducting glaucoma care programs in 3 African countries, Burkina Faso, Ethiopia, and Mozambique. And what they do is human resource capacity building. So glaucoma specialists are being trained. Infrastructure development, so the hospitals they work in are being equipped for glaucoma care, and public health, education, and awareness. So one of the things that struck me with what Svenja does is procuring equipment for glaucoma care in these countries. And as you would know, we have a myriad of all kinds of glaucoma care equipment, from the least expensive to the most expensive. So it was really a challenge to first decide on which equipment to procure. What are the other uses? For example, if you want a laser, if it's going to do this, if it's going to treat glaucoma, what else can it do? And would you need it? Because the need is there. So Svenja will be telling us about those challenges and how she overcame them and the lessons learned, so that we don't have to go through what she has gone through again. Yes. So thank you, Svenja, for sharing these experiences.
Thank you, Fatima, for the introduction. Good afternoon, everybody. So it's a huge pleasure for me to be part of the second IAPB Focus on Glaucoma series, and even more so among such a high-level panel in the Africa webinar. So my name is Svenja Schneider. I'm program coordinator for Eye Health at Light for the World. And in the past 14 months, I have been accompanying our multi-country pilot initiative to address the challenges of glaucoma in 3 African countries, namely Ethiopia, Burkina Faso, and Mozambique. Maybe as a very quick contextualization, the program is called Silent Thief of Sight, and it's composed of 3 main lines of interventions, the first being human resource development, the second being the development of the glaucoma toolkit, the very guidelines that Dr. Nkiru just presented, as well as the third line, the building up of infrastructures of a couple of glaucoma centers in our countries of intervention. So we are presently equipping 5 tertiary units to ensure specialized glaucoma treatment. We're equipping 1 training center in Addis Ababa for the glaucoma fellowship program at the Menelik II Hospital, which is led by Dr. Abeba. And also we are supporting 2 secondary eye units to make sure that they have the conditions in place to play an adequate role within the referral pathway. So in the past year, we have had to deal with, and are still dealing with, the questions of how to equip the eye health professionals adequately to deal with glaucoma in a manner appropriate to their respective setting and their working context. So my presentation will be very practical, sharing the experiences we have had in the past year. And I've structured our learnings in 4 categories. First of all, how we made our decisions, how we assessed the need in the centers we work with. Secondly, how did we get these machines that we had ultimately chosen? Thirdly, beyond the patient services that we, of course, aim at mainly, how can the equipment that we purchase also have even more added value? And last but not least, some thoughts that popped up throughout the last year when we were trying to find the best way. So as a first step, of course, we needed to base our decision on a couple of issues. So I think we can say that it was a bit more than a needs assessment, rather a situation and analysis. As a very first step, we made use of the IAPB Essentials List. We used it to develop a template, which we shared with the involved centers in order to understand what their inventory is, so what they already have, what they don't have. I think I should highlight that we're talking about completely different scopes in every center. So we're talking about tertiary centers that don't have a vision field analyzer, but we're also talking about places that have rather sophisticated equipment, but some of the basic equipment is not in a perfect state. What we took into consideration is, of course, the level of services. Very important if the professionals are already in place. So is there already a glaucoma specialist or not? In most of the centers, there isn't. They are currently being trained. Especially in the centers where there already is a professional, the experience that they have was very important to us. So what is the felt need? So don't get too stiff with orientation on the needs list, but really say, what do they feel? What is needing to complement their services? What is their personal preference in terms of brands, in terms of technologies? A very important factor is, of course, the maintenance and the suppliers. So what are the brands that are presently being used in these centers? What are the most common brands in the country? But also when deciding what items to purchase, focusing on a limited number of brands to make sure that servicing is not made more complicated than necessary. Of course, we looked at the servicing. Is the maintenance possible in country? Is there a supplier in country, or at least in the region? Or is external servicing, so somebody flying in from the region, possible if really necessary, and also reasonable in terms of the scope of equipment that would be there? We also thought that it would be really important to assume a comprehensive view. So also look at the basic equipment there, because of course it's fantastic to have all the surgical and diagnostic devices in place, but if the autoclave is not working, this is a massive issue, of course. So this is something that we also included in our assessment. And depending on how well the specific center was equipped, we also looked at combined devices. So of course, some centers have already very specific devices. So punctually, we can, it made more sense to purchase devices for a single type of treatment, but for others that are very basic, we thought it would also make sense to look a bit more in the future and to think, okay, what are the other specialties? What are the other diseases that will be looked at a bit stronger in the next couple of years? In terms of process and collaborations, how we proceeded, we as Light for the World work with a procurement partner who does all our collecting the offers, doing the importation process, the shipment. Of course, after getting the offers, there were a lot of feedback loops with the partners, but also with our expert advisors, because we had to see how to prioritize in a context of a big need, but very limited resources. And in this context, we found that planning a major purchase of for several eye units in a multi-country initiative put us in quite an interesting position and opened some nice collaboration opportunities. So specifically, we approached SAIS and requested an offer for all the devices that we needed in the 3 countries that are produced by SAIS, obviously. And thanks to the very high volume that we intended to purchase on the one side, but also the specific interest of SAIS in the topic of glaucoma, we received a considerable discount. And this allowed us to purchase a much higher volume of high quality equipment than we could have originally afforded. So this was a very, very fantastic opportunity for us. We are furthermore negotiating with some suppliers to receive some donations of equipment for trial, because some of the devices are, well, have been proven to be useful, but in the very restrictive, in the very limited budgetary context that we work in, we cannot guarantee, we cannot afford them at this moment. So this leads me to the next point, which is the link to clinical practice and research when talking about procurement. So firstly, of course, we based our decision on research, but on the other hand, especially for the centers that already work with a specialist, intended to use the equipment that we purchase also for research. So, for example, new devices or devices that are new in that specific center can be used for randomized trial control and can ultimately be used as an argument to invest in the specific device also in the others in the other centers. So we really wanted to foster learning in a context of limited resources. And we're still working on some cooperations to get donations of equipment for research. For example, some technologies such as MLT, which is presently too expensive to purchase for us, but reported to be extremely valuable. So we're trying to convince suppliers of certain technologies to potentially donate devices to centers which already work with a professional in order to provide the argument to invest in these items in the future if they prove to be useful in this low resource setting. So we have to look at the consumables that are used for it, as well as, of course, the usability of the device. And last but not least, there were some ethical considerations that made us worry a bit. So we thought, does it make more sense to assume a gradual approach, to gradually equip the centers, to have learning for most of the devices, or really preparing the ground and purchase a lot of devices to ensure that after diagnosis, there is a broad range of treatment available on the ground in order to ensure that we don't end up diagnosing cases and not being able to treat them. The other point are technologies with very, very high costs that address small groups, but that definitely need relief. So that's something that we haven't really found a solution for yet, something that we might look at in a second or third phase. And the last point is, in this context where some technologies that have proven useful are too expensive, is it ethically acceptable to bring used equipment to some centers? Of course, there are legal regulations in some countries, but this is also something that we are still assessing as an interim solution. But of course, this is a whole different discussion that I don't want to open up now. Yeah, so maybe to conclude, I will just inform you that the first order is about to be delivered to the 3 countries, and next year we will be able to talk about the impact that the equipment that we purchased had on these centers. Thank you so much.
Thank you. Thank you, Spania. That's fantastic news at the end. Even though everything you said was quite amazing information. It's really important, you know, the level of services, the professionals in place to be considered when purchasing equipment. And what struck me was buying plenty, you know, a lot of equipment at the same time, which brings down the cost. So if we can come together as a group and make the purchases at the same time, it might just be a lot better. And this is just about like the step one of what we were thinking on improving services for glaucoma, that is to equip tertiary centers or centers for high quality glaucoma care. So thank you, Spania. Thank you, Light for the World. And oh, and by the way, she also gave us a topic for next year's webinar, which is impact of the equipment used in the Light for the World program. So here we are. I'd like to introduce the next speaker, who is Dr. Kola Ogundumu. He's from Sight Savers. He's going to be telling us about Sight Savers' perspective on the KEEP site for glaucoma in Africa. Dr. Kola Ogundumu is a trained ophthalmologist with about 2 decades of experience in program development and management. He's the senior technical global lead for Sight Savers. He also leads the KEEP site project in Nigeria. Kola?
Thank you, Fatima. And thank you to the other speakers for all the exciting stuff that has already been shared. So I'll be speaking about Sight Savers' experience and the KEEP site project very briefly. But before we go into that, a very quick quiz, but no answer yet. So the following statements describe the main contributors for glaucoma blindness, except there's poor awareness of glaucoma as a disease. Early glaucoma's symptomless nature means the disease is well advanced before patients seek treatment. RAP surveys underestimate the prevalence of glaucoma. The available treatment options are inadequate, and there are not enough human resources, and those that are there are often not having the necessary capacity. We'll come to that at the end of the presentation. So a quick overview of some of our previous initiatives. Glaucoma has always been a part of our comprehensive eye care projects in district health projects across Africa. And we realized there were mixed results. And regarding outputs, and absolutely no results at all, no information regarding quality. And even when equipped for glaucoma management, practitioners often restricted themselves to medical management, and that without sustained follow-up. And patients themselves were often unable to sustain treatment, but that was not only due to cost, but due to many other factors contributing. The IEC materials we used encouraged people to go for screening, but this rarely really happened, except the patients were visiting the clinics for other purposes. Then opportunistic screening opportunities were often missed in the clinic because not all patients had a full examination. So the inability to have quality information from the limited indicators meant glaucoma, or rather the inadequate service for glaucoma wasn't really well appreciated and wasn't very visible. We've also worked in glaucoma subspecialization, supporting through the West Africa College of Surgeons, but distribution of subspecialists is still limited. And the concern that is obvious there is that even as we develop subspecialists, they are still largely focused at the tertiary centers, and that means at the capital cities or very big urban centers. We also did something about training general ophthalmologists and observed if we could train and mentor general ophthalmologists to do glaucoma management. And we're focusing in particular on some diploma level ophthalmologists, and having supported them, trained them well, and given them the mentoring over 5 to 7 years, and the projects were handed over in 2014. We left them for about 4 years, and in 2018, reviewing it, they had sustained glaucoma surgery in 3 out of 4 projects, and with good reports regarding safety and outcomes. So this just shows that it is possible to have a good level of glaucoma management, even surgical, at the secondary and district level. So the initial pilot of our site project is to establish the protocols and procedures that will underpin a public health effort that will, in the future, provide safe and good quality glaucoma service, and therefore reduce the incidence of blindness due to glaucoma. We soon realized there were other people already doing some work, including Light for the World. We've already been partnering with Warfield Eye Hospital on wax. So we joined the efforts to develop the Africa toolkit, adding the M&E indicators that we have added, and we'll continue to collaborate on that toolkit and implement that in our pilot and provide information to refine it as we go. And then we are also aiming at developing behavior change strategies that are aimed at moderating or modifying the attitudes and practices that contribute towards the low uptake of and compliance with glaucoma screening and management across board. So the kind of training we have in mind and which we are beginning to implement, and the actual implementation actually starts this week. We did an initial screening pre-pilot on World Sight Day, but the main project has just started. And we want to look at training general health practitioners at all levels, from primary health facilities to general practitioners, not to treat them, to let them know how to treat glaucoma, but actually to give them the awareness of the disease and of certain risk factors that they should then inform their patients about and trigger a referral for screening. And the objective really at this level in the public sphere for this point, at this time, is to identify people who are at high risk of blindness from glaucoma, so that we reduce the incidence of people coming to the clinics when they are already too late, when there's nothing that can be done. So they'll be provided with information charts, posters, and leaflets and more as we develop the behavioral change component. And the objective is that people who meet the agreed criteria will be encouraged to go for glaucoma screening. So this is case identification of high risk persons at high risk of developing glaucoma blindness. Then training continue now onto the eye health professionals. We want to enhance the training of ophthalmic nurses and optometrists and other people in order to ensure good and well standardized based on the protocols screening for glaucoma. We have identified a glaucoma specialist at the tertiary level who is the technical anchor and will be the clinical lead and will provide training and guidance and mentoring for the general ophthalmologists who will be recruited into this pilot, who have started being recruited. And they will receive training according to identified needs. So this will be, they will be matched against the protocols and standards, and the training will be developed according to what is identified. And that will be led by the subspecialist. Longer term, we definitely would want to embark on wider skill and larger scale skills improvement for general ophthalmologists, as well as strengthening the regional pool of subspecialists. But I want to note that subspecialty practice is important and crucial to long-term high-quality management of glaucoma. But we do believe that a singular focus on subspecialty practice is not an option, for reasons that I think should be obvious to us in terms of access to the service, access to the places where the subspecialists are available, and the costs. We need to bring glaucoma management, good quality management of glaucoma, closer to the wider public who do need it. An effective public health campaign aimed at encouraging a culture of self-referral, developing as Abiba and Light for the representatives from Right for the World has mentioned, developing the referral and uptake and counter referral systems. That's also very important. And as Abiba also mentioned, strengthening opportunistic screening, and not just screening, but providing them with information about what they have been identified for at all opportunities, including unrelated eye care interventions for adults. This will definitely go some way to reaching people who are at high risk for glaucoma. So we do believe there needs to be a holistic and integrated approach. Déjà vu, I think I'm just repeating what others have said. And we look forward to scaling up to a full state in Nigeria and towards a wider national glaucoma project over the next few years. So back to the question. So the following statements describe the main contributing factors for glaucoma blindness, except there is poor awareness of glaucoma as a disease. Yes, there is poor awareness of the concept of glaucoma. Talk less about how to manage it. Early glaucoma's symptomless nature means the disease is well advanced before patients seek treatment. That is unfortunately very true, and is the bane of our treatments these days. Every clinician sees patients day in, day out coming in at a point at which nothing can be done, little or nothing. The RAB surveys underestimate the prevalence of glaucoma. That is true, but we have evidence from other sources. So in itself, that may not be bringing the evidence up to the forefront, and we'll look at what we can do about that. But we have the evidence about the prevalence and the impact of glaucoma. So that's not really the case. The available treatment options are inadequate for the proper management of glaucoma. And then there are not enough human resources for eye health to manage glaucoma, and those who are available often do not have the capacity to manage and follow up their patients. And yes, actually, it is that we do know that even with the limitations of existing treatments, if properly applied, the majority of people will actually stabilize or slow down the progression to the point that they are able to retain useful vision for life. Only a small number of patients, depending on studies, but some 10–15% actually continue to progress uncontrolled. So we do have what we need. We do have the information we need to make an impact for the majority of people. And it is time for us to take those steps, as other people have said. So thank you very much. And this is where I will stop. Fatima?
Thank you, Kola. That was a very interesting presentation, and it is such a good feeling to know that Sight Savers is joining. I mean, is implementing the toolkit in a pilot, develop as we go along, collaborating with everyone else that is doing glaucoma care, joining hands. And also, the striking thing again is the behavioral change, starting from the general practitioner, the healthcare workers, and all awareness at all levels, not just for the healthcare practitioners, but also for the people. and then bringing glaucoma care closer to the people. So that is really exciting. And we have the thing that it takes. So we have to put our hands together, our heads together, and do what we have to do. Simon, is Simon here?
Yes, Fatima, I'm here. Thank you.
Thank you very much for all the panelists. I'll hand over to Simon, who will now take over the conduct of this. I don't know if there are any questions for the speakers. Simon?
Firstly,
Unmuted.
thank you to you for such a great anchor for our. Apologies to everybody for the
I think we may have lost Simon, but we do have some questions. Simon, can you hear me? So there was some questions for the speakers. So I'm just going to read some of these out. So Dr. Nikari, this is a question for you. Is the new toolkit in use at the moment?
Dr. Nkiru.
Okay. No, the toolkit is not yet in use, but it's going to be piloted in Nigeria, which Kola mentioned. It's going to start this week. So the pilot is going to test the document, the toolkit, and fine-tune it. But it's a great document that I'm sure by the time the piloting is done, we will find very, very useful.
Excellent.
It's also going to be piloted in Ethiopia. So we have two amazing opportunities for piloting the toolkit. One in Nigeria, and they're all very new programs, and one in Ethiopia, in Gonda. So it's also a kind of a program that involves tertiary institutions, communities, and secondary institutions. So similar situations to pilots, two different countries, and it's a toolkit is an ongoing, development process. So there's going to be iterative changes because of the way how we apply it, what we find, and within 2 to 3 months, I think we'll get a better guideline than we have today, and that will be the one that will be launched and disseminated and used. And by the time it's going to be used, it's free, available for all. Thank you to Sight Savers and Light for the World.
Great, thank you.
Next question.
And how would someone get the toolkit for use at the clinic when it does become available?
It's going to be free online to start with, and then it's going to be disseminated to centers that have participated, and also all the centers. We have a network that will find ways to distribute.
Okay, perfect. Thank you. And Abeba, this is a question for you, I believe, is from Frank Albert. I like the 5 platforms of glaucoma care that can be integrated. Would like to add a 6th platform, which is the DR screening program through fundus cameras. This can also be a platform for glaucoma care. So it's more of an opinion, I think. But is there any comments around that at all?
Okay.
I can't see Abiba talking. So yeah, good addition. But I think that also falls in the NCD's program, the non-communicable diseases, which diabetes and diabetic retinopathy is part of. But yeah, that's another platform for integration. Kola, you were going to say something about this.
Yes, just to mention that I do feel that is actually the person is actually quite correct, and we should be looking at integrating or somewhat aligning these two areas of technology, which actually not only overlap, but actually can provide multiple diagnoses at the same time.
Yeah, excellent. I think that's, yeah.
Both in terms of technology, the equipment itself, and the AI that accompanies them.
Yeah, yeah, it uses the same technology, isn't it? Imaging.
Yes.
Thank you.
Brilliant, thank you. And here's a question for Svenja as well, but also to the others, if anybody does want to offer any comments. With regard to using equipment to test glaucoma, can anyone share lessons learnt with the use of smartphone-based peak retina by CHWs to detect glaucoma on community level?
Then yeah, here unfortunately we cannot really share any experience on this yet, because we're presently at a stage of first equipping really the supply side, so the tertiary centers, and we're not as far as reaching out to the communities at this point. But I hope others can tell more about that important issue.
Well, unfortunately, again, we don't have that information yet, so it will be unfair to make any comments about that for now. But I think PEAK is one of it's been developed more for screening, visual acuity screening, and in children, school eye health, and it's also been developed for screening of fundus pictures and all that. So, but we don't have the information yet, so it will be unfair to make any comments on that.
Okay, thank you. I think we've run over quite a lot, and so I don't think we really have any more time for any more questions. Fatima, I don't know if you want to sort of wrap up now.
Yes, please. Can I have the next slide, or is it the? Yeah. So thank you everyone for talking and for listening, because I think this is a very important topic, and we feel that if we standardize glaucoma care, we'll reach more people, and with all the programs that the program developers are instituting, we feel that glaucoma care will reach more people, and perhaps earlier detection and then prevention of blindness. So because of some of the works that we have doing, we have a fantastic offer from Professor Peter Shah of University Hospital Birmingham. This is more of a training kind of thing. They are developers and promoters of the International Ophthalmology Portal, that is IOP.vision. It is not a free resource, but it is an immense resource for ophthalmology knowledge. I found it particularly useful for surgical pearls in the management of glaucoma and cataract surgeries. Like, you could just click on a video and it will show you the step-by-step trabeculectomy and the pearls for, ensuring success. And it takes you through every academic knowledge stuff about trabeculectomy. So the good news is that he has offered 100 participants from Africa free access to this enormous source of eye care information and videos. So if you're interested, you'll have to send me your email address with your first name, your surname, institution or place of work, whether it's private or government. Not that it will change, but it's just for our records, which country you practice, and especially your email address, and then of course the consent to contact you for any glaucoma related activities. And we'll put your name up together to the information access to get an access code to IOP.vision. So thank you very much, Professor Peter Shah. And thank you everyone for listening. Thank you for participating. This is focused on glaucoma. It's World Glaucoma Week, 8 to 14th, 2020, 8 to 14th March, 2020. Let's all get our eyes tested. Thank you.
Thank you, Fatima, and thank
Fatima,
you.
thank you. Sorry, thanks. Fatima, thank you so much. And thank you to our presenters, Dr. Akarawai, Abeba, Dr. Schneider, and Dr. Ogundimu for their comprehensive presentations and the responses to all the questions. Rachel, I'd like to thank you for fielding all the technical issues from the global office and also for arranging this webinar. Also, I'd like to thank our audience, everybody who participated. We really appreciate you all taking the time to be part of this Focus on Glaucoma webinar. We had 199 people register for this glaucoma webinar, which I think is in fact an IAPB record. So thank you for your support and for your interest. We do hope you've learned something from it today. And if you would like more information on the subject, please do drop us a line. For more on IAPB's campaign on Focus on Glaucoma, please visit our website, iapb.org, to learn more about the various activities and to see how you can become involved. Also, if you'd like to visit the website in the coming days, you will be able to access a recording of this webinar, and you'll also be able to download the slides from all of our presenters. Shortly after we wrap this up, you will receive a survey via email, which will come from Rachel, and that will be that'll just take a few short minutes to complete. And we'd appreciate it if you could just give us your feedback. It lets us know more about what everybody thinks of these webinars, what they've liked, and what you'd like, whether there's anything else you'd like to hear about. So please do look out for that, and also please keep an eye out for the next IAPB webinar. So I think that's it from us. Thank you very much, and be well.
Thank you.
Thank you.